Increasing annualized revenue by reducing emergency department left without being seen rates is our episode topic. My guest is Alison Harmon, Director of Nursing for the Department of Emergency Medicine and Transport Services, as well as the Director of Nursing for the Crisis Stabilization Unit at the University of Iowa Hospitals and Clinics. This topic is being co-presented by Allie and I during a performance improvement mashup event held in conjunction with the Emergency Nursing 2024 conference, which will occur September 4th through September 7th in Las Vegas, Nevada. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Allie, thank you so much for joining us today.
Pleasure to be here.
Now, your organization at the University of Iowa embarked on a multi-year performance improvement project called Better Teamwork, Better Care. What were the aims of the project?
So in terms of the entire project, the goal was to just look at our throughput opportunities for efficiency from the inpatient side to access to emergency department. One of the areas that we really focused on in the emergency department was our left without being seen rate and looking to see what we could do within the ED to improve our flow and the care we provide.
Yeah, so you can talk a little bit more about what your left without being seen rates were before this project started.
Before the project started, we had an average of about 7.5% to 8% left without being seen. So that for our volume was about 10 to 11 patients per day. So the goal was to obviously drastically reduce.
For those that don't have a background in emergency nursing or have not had the chance to oversee an emergency department, can you talk a little bit more about the impact of left without being seen on both the hospital and the patient population?
The impact is more than just the financial. I know a lot of folks will go to the financial of what patients walking out the door not receiving care, but we also look at it as what is the impact on that patient? Was it a patient that needed care that can negatively, impact the timing of their care, delays in care, increased risk, not being seen can lead to devastating outcomes. Also, just the general community perception of our emergency department. We want to have the community come to us in their time of need. And if they feel they don't have access to care, they'll go elsewhere. And within our community, there is no other ED that's outside of UI healthcare. So for us to not be able to treat our own was something that also weighed on our team's mind.
So you're in a monopoly environment?
There is another ED, but it is under the UI healthcare umbrella.
Okay. No competitors in the area.
Not in our community. There are some in the region, but they would be leaving our area to go receive care.
Understood. What were some of the reasons why your left without being seen was high?
There were many contributing factors, nothing that is necessarily unique to Iowa or unique to our institution. I think it's issues that emergency medicine is facing as a whole. Everything from mental health resources not being where it needs to be. A lot of times our behavioral health patients board for a long time. Hospitals being at capacity, not having the throughput that we'd like to see. There are struggles with patients who no longer need to receive hospital level care, but need to go to a skilled nursing facility, not necessarily being able to get to those facilities in a timely manner. So then they stay at the hospital longer. There's multiple factors that go into what leads to throughput challenges in the ED, which increases your left without being seen rate when you lose that ability to care for new patients that come through the door.
So you had this challenge or this higher than desired left without being seen rate. And University of Iowa decided to partner with BRG's emergency care solutions team to work on improving those left without being seen rates. Can you talk a little bit about the interventions that were used for this project?
Yes. So a few of the things that we did was really just started to formalize some of the processes that we already had in place and then talk about them in real time. So one of the things that we BRG really helped us with was getting visual dashboards that had all of our metrics on there. And then from those metrics, sending out daily emails to the team, not just leadership, but frontline team members who were invested in the process so they could see what was going well, what wasn't going well. On our provider side, they also created dashboards that helped with our medical directors being able to see outliers in providers and engaging them in performance improvements. We also implemented huddle strategies where we talked about what we were doing and what our not only our data was, but any struggles or any challenges that we might be facing that day and how we were going to really address them as a team. We also looked at our composition of patients that come in and looked to see if we had an opportunity with our lower acuity patients to get them in and out in a quicker manner. So we had a low acuity strategy where we would put them through the system so that we could spend more time with those patients with the higher acuity. We worked with BRG to really develop and strengthen the nursing leadership team, which I don't think this is unique to UI healthcare, but a lot of leaders right now are younger because there was a shift in nursing over the last few years with COVID. And so we have younger, newer leaders. And so we had kind of a nursing leadership academy, I would say, a 1 day coaching that we started in the ED and then it actually spread to our inpatient colleagues as well. And that was really well received. And it just helped not only fill nurse leaders' buckets, but answer some of those questions and give perspective and insight on how to address difficult situations.
One of the things you talked about was sharing the data with the frontline staff. How did they react to that? Because I know in some circumstances, frontline staff's perceptions can be, oh my goodness, here we go. Administration is just shoving these metrics down our throats. And others tend to embrace it. So, how much of that is how it's being presented? How was it presented for you and to the team? And what was their perspective on that?
So I had that concern. Was concerned that the team would see it as here's a report card. I'm going to be judged on how well, quote unquote, I did or how poor I did in a day. And it really had the opposite impact of what I was anticipating. The team embraced it. They wanted to know how many patients did we see? I felt like I was so busy in triage on Monday. Tell me what my numbers were. Oh, this one, I knew that guy was going to leave. I didn't want him to leave. They knew down to the patient who had left. And there was such a sense of ownership and pride. And the number of text messages or emails or stops I get in the hallway from team members that said, "Did you see my numbers?" It has just really changed that culture. And I would say that the nurses were all in on the process because they just had the sense of ownership and pride of our triage area and what we were doing to reduce our left without being seen. So it really became one of those things that they were proud of, but they also would, in a supportive, jokey way, be like, "Hey, did you see my numbers? Your numbers didn't look like that. What happened?" And it's sparking conversations and there is a little bit of that friendly competitiveness, but we're having more conversations now about processes than we ever did before. And so I think it's just been a really positive change. And they're the ones to tell me if there's ever a hiccup with information or, hey, I didn't get the email. I normally get it at this time. Why didn't I get it at that time? And things like that. So I think it's been really powerful. And it's really, like I've said, given them that sense of ownership over the process.
Getting more into the emails a little bit, a lot of organizations are using Tableau or some other type of analytics software that can give them a lot of high-powered data and analytics. What information is on these emails and what is not? Sometimes that can be overwhelming for frontline staff. So how do you find that balance?
So we worked with you guys to tweak the format and who received them and things of that nature, because I agree they can be a little bit overwhelming, but ours are pretty clean. There's what we call like the pertinent information forms. How many patients did you see? How many left without being seen? And those are the two big things that I would say they look at every single time. So those are the ones where they go immediately. And then there's also the month to date information. So this month we've seen X amount of patients. our budget, our normal census is X amount overall for the month. Our left without being seen rate is this. It breaks down our acuity. So they'll see on some days like, oh, there were 11 people that left. That's an anomaly for us now. That's no longer the standard. That's an anomaly. Let's break down and look at that. We can look to see and say, oh, it looks like we had a lot of level twos or level one patients, or we were boarding, things like that. So it gives that pertinent information that the team really likes having at their fingertips.
Who all's getting those emails?
So it goes to our leadership team, but it also goes to our charge nurses. And because that is their responsibility to share it in the evening. And then it goes to what we call triage leads. So those that run the triage area. And from there, anybody who honestly has said, hey, I'd like to start being a part of either the triage committee or seeing information about this, we've been very open to adding them to that. But it's generally our leaders of triage, our charge nurses, and then the leadership team.
And so part of this process also included forming a work team. You talked about a triage committee, which you had existing before this project went underway as well. What are some of the things that work team did or work team focused on?
The work team that we put together was multidisciplinary. It had everybody from the frontline nursing to our physician group to our APPs, but it also had radiology, our registration staff, our patient account reps, social work, things of that nature. And the reason that it was multi-D is because we needed all those players at the table to help identify other throughput challenges that the ED was having. The group really focused on what can we control. We as an emergency department, what do we have ownership of and what can we control? We didn't necessarily want to focus on throughput throughout the institution. I feel like that is something that EDs do at times is say, we can't do anything because of inpatient bed availability. We wanted a group to take ownership of our space and what we were able to do. And so that group looked at everything from what's the best way to communicate with radiology that there's a patient in the waiting room who needs an x-ray. What should the workflow look like to how do we ensure that our registration staff are capturing these patients who received full cares in our triage space so that we know that they are checked out properly and they have their information and things like that. So this group really just focused on ED processes and how everybody plays a part to ensure smooth, timely, efficient care.
You talked earlier about some of the leadership training. You called it a leadership academy, a one-day boot camp, so to speak. Can you go into a little bit more detail about that?
So it was a mini boot camp and it just talked through everything from how to have a crucial conversation to there's a Harvard study on it's going to sound a little bit odd, but making sure that you're not taking on someone else's monkeys. So what problems are you taking on that you should be working to delegate to give to others? And how I feel like I know that the training was successful is that even outside of the ED, I've heard people say, not my monkey, or I'm going to take that monkey from you, or I'm going to give that monkey to somebody else. So it was a lot of how do we streamline work? How do we have those difficult conversations? And how do we balance load and make sure everybody's pulling their weight and really being a part of the team?
What were some of the broader strategies that were employed in this project? Because the emergency department left without being seen was just one part of a very large enterprise performance improvement project that was focused on resource utilization and workforce structuring, but also inpatient throughput. So, can you talk a little bit more broadly about areas of focus?
There were groups that were dedicated to looking at do we have the right makeup of a care team at the bedside? So, looking at the resources, who's coming when, things of that nature. There was also a team that looked at geolocalization. So, are our providers spending their day traveling to 12 different units to see all of their patients? How can we be more efficient and have the patients cohorted on the right floors so that the providers have fewer, they don't spend their day traveling. They have everything they need right there. So, they worked really a lot on service based geolocalization to make sure that the right patients were in the right bed with the right care team caring for them. We also worked with our bed management team and system to really do centralized bed assignments. So, our bed management team, we transitioned a process from the charge nurses of the unit really taking ownership of placing patients, assigning patients, things of that nature, to giving that over to our bed management team. And what we call our admission transfer center, they now are placing the patients in the bed when they become available so that the charge nurses can focus their time and energies on other things. We looked at ensuring patients were assigned the proper area, whether that was observation, inpatient, that their lengths of stay were matching what they were needing. And through that process and to have those conversations, inpatient teams did a phenomenal job of implementing huddles. And with these huddles, making sure that the providers who are now geolocalized and can attend huddles with the nursing team and our care coordination team are able to do so. Everybody's on the same page regarding a patient's plan of care.
Focusing back in on the emergency department, what were some of the results of the project?
So, our left without being seen rates, as I mentioned, they were originally at about 7.5%. They decreased to about 3.29% overall during the process improvement period. There were several months in there that we had a left without being seen rate under 2%, which was just phenomenal. Financially, this is about a $3 million additional revenue that we were starting to see. But more importantly, that means we were able to see so many more patients each day. I do also want to call out that during this period that we'd seen a drastic decrease in our left without being seen rate, our volumes went up. Our census was higher. I don't know if there was a correlation there that the word was out that we could see more patients, or if it's just trends throughout the area that volumes are going up everywhere. But through that, we've been able to maintain a decreased left without being seen rate while also seeing more patients. And there were some days that we were seeing significantly more volume than what we were used to seeing.
Any changes that you needed to make around staffing related to this performance improvement project, and especially with your volume being up a little bit?
So, not a lot of changes as far as the FTE of staff that are present at a day. We did look at adjusting the coverage based on trends we were seeing, but even those changes were very minute. It was maybe decreasing an RN FTE from 3 a.m. to 7 a.m. and putting it more in the heat of the day. We're still looking and tweaking to make sure that we have the appropriate number of staff during our highest points, looking at a 5 p.m. to a 5 a.m. nurse, which is where we would really need one instead of at 5 to 7 a.m. But no, we have not had to change our FTE. We have changed how we assign staff. We have pushed more staff to the front of our house, AKA to our triage space, but we haven't changed our overall staffing model.
What were some of the lessons learned for you and for the department as a part of this project?
One of the biggest lessons for me as a leader during this was just it reinforced the need to have your frontline staff bought into changes. You not only need to have them bought in, you need to have them there on day one so that they can have a voice because they're the ones that are out there doing it all day, every day. And so they have ideas. I feel like our team has always done a great job of having nurses and physicians work hand in hand on new initiatives and projects and brainstorm. But this one really challenged us to include all areas that interacted in the ED. As I mentioned, we had radiology, social work, our patient account teams, things of that nature. I felt like that really highlighted to the entire emergency medicine department that this is a priority. We want all hands on deck. We want to all be on the same page. And so that was just my biggest lesson is make sure that you have those teams represented and you have frontline staff there and at the table making the decisions because that's going to help with your buy-in and with the support moving forward.
Let's fast forward to today. How are things being sustained? What are some of the wins that are still occurring? And what challenges, whether they're new challenges or old challenges, are resurfacing?
I'm very happy to say that our workflows and our processes that were implemented in our triage spaces are being maintained. The nursing team remains engaged and they are continuing to be the biggest champions. I still get the text messages saying, "Hey, did you see my numbers?" I get those just as many as I did when we first started the project. So that is my biggest win. As far as our challenges,
And
we,
we're well over a year after we went live with this. So
yes,
a year later, you're still getting text messages about engagement and success.
yes, a year later, I am still having people come to me and say, whether it's a great day, "Hey, did you see my numbers?" Or if it's a bad day, saying, "I have an issue with those numbers and let me tell you why," because that's how bought in this team is. And that's their ownership of it. They really unlike most other projects we've rolled out, this one has had staying power and I love it. We still have our triage committee that meets. We still have the same work group that meets. And it's not a, hey, do we have to have that meeting? It's when is the next meeting? Because I have topics that I wanted to discuss. So it has been a great thing for the overall culture of the ED, I feel like.
And is it really just about the numbers, or is it, again, still about they're seeing the translation to better patient care?
I think the numbers is just a way to have the conversation. We had what I feel like is not unique again to EDs throughout. It's not a unique to Iowa. We had moral distress in the department. We had waiting rooms that had 30, 40 patients in them. We had staff that felt like they weren't giving the level of care that they wanted to give. And they said, I just feel like I'm moving people through a machine. I'm not engaging with my patients. I'm not giving the best care possible. And that has shifted. So we are able to get patients who need to be admitted back into the beds where the team back there is able to care for them. And the patients that are in the waiting room are no longer just sitting there waiting. They're actually moving through the system. And so nurses are having regular touch points in with these patients. Yes, they might be receiving the majority of their care through triage spaces, but they're being checked up on and they're being seen. And this is correlating to the comments we're seeing from our Press Ganey results. Patients, yes, they understand they're moving through a system in a different manner, but they are happy to be seen. They feel like they've been seen. They feel like they've been heard. And that has translated to the nursing team as well. They really feel like they're able to actually provide care to patients now.
And I interrupted you on your response earlier, but fast forwarding to today, what challenges have you encountered? And circling back to that question, how are things still being sustained?
Yep, we're still sustaining those triage processes that we implemented. As far as challenges, we do continue to experience challenges with throughput to our inpatient colleagues. However, I'm just going to say that the Better Teamwork, Better Care initiative has helped to really implement pathways where concerns are discussed when we're having challenges with inpatient units. So we're having conversations every single day with inpatient leaders, with our care coordination colleagues. And this has not only strengthened our rapport across all the disciplines, but it reinforces our daily mission of providing the best care that we possibly can. So, yes, we're still having those challenges, but now we have pathways to work through them. We have the relationships built so that we can discuss and get patients where they need to go. So, yes, there's still boarding challenges, but I feel like we have systems put into place to address and get patients where they need to be.
Now, you worked with BRG on this project. What was that experience like? And please speak freely, openly, and honestly. What were your thoughts initially when you had, oh my gosh, they're bringing in consultants? And what was that experience like? And what are your thoughts afterwards on wins and things that didn't go well?
Yeah. So, honestly, I felt like BRG was great to work with. I would say that even if you weren't the one asking me the question.
Thank
It
you.
was yeah, it was a interesting process just because it was different from other consultants that I'd worked with in the past. This seemed to me to be a whole house approach. It wasn't just focused on one area, one unit, or one discipline, or one specialty. This was a whole house approach. And so it was nice to see that, to be honest, to get a complete overview of here are our strengths as an institution and here are opportunities. So, how as a team are we going to get to where we need to be? And so, I think having it be better teamwork, better care, having that name around it really just tells how the process was. I really felt like UI Healthcare and BRG really did work as a team to get to where we are now and see the successes that we've seen. So it was a great experience. And it's always nice to have outside perspective that can speak to what they've seen work, what they've seen others try, and be able to connect you with various resources. So for me, it was wonderful.
Any closing thoughts as we wrap up this episode?
No, thank you. This has been wonderful.
Increasing annualized revenue by reducing emergency department left without being seen rates has been our episode topic. The key takeaways I heard were: one, the need for daily performance metric sharing with staff, as well as two, multidisciplinary frontline staff empowerment in the performance improvement initiative. Allie and I will be co-presenting this performance improvement project during the PI Mashup event held at the Emergency Nursing 2024 conference, which will occur September 4th through the 7th in Las Vegas, Nevada. Allie, thank you so much again for your time today.
Thank you, Nick.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.